Hello Health on LAE is presented by the Oxner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxner, healthcare with peace of mind.
When Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with WLAE, the Oxner Health System, and Humana to bring Oxner's Hello Health weekly education and information series to television. Tonight we're going to be talking about stroke and stroke prevention. Our guest is Doctor of Osteopathic Medicine, Dr. Daniel Chehebar. In the second half hour of our program, we'll be taking your questions live by phone, like we always do, at 504-866-3200. That's 866-3200. And by email. You can email your questions to us at this address, hhquestions@wlae.com. You can send the questions by email now. We'll ask you to hold off on the phone calls for a short while. Well, Dr. Chehebar is originally from Long Island, New York. He received his medical degrees from Nova Southeastern College of Osteopathic Medicine in Fort Lauderdale, Florida. He completed a neurology residency and clinical neurophysiology fellowship at Penn State Milton S. Hershey Medical Center. Dr. Chehebar led the establishment of a certified primary stroke center at Rockingham Memorial Hospital. That's in Harrisonburg, Virginia. That was in 2012. He moved here not too long ago. We'll talk about that too. He is board certified by the American Board of Psychiatry and Neurology, and it is our pleasure to welcome to the program and to our city, Dr. Daniel Chehebar. Good to have you with us.
Thank you very much, Tom. Thank you for inviting me.
You're welcome. Well, how did you end up in New Orleans, and we're glad you're here?
Actually, a colleague that is with the Oshner system now that I worked with in Virginia recommended I take a look and come on down here, and since I've moved down, have been absolutely thrilled and very happy with the people and the environment down here.
Good, and you've found our restaurants. You mentioned to me, yeah.
Yes. I found about 20 extra pounds I didn't know I had laying around also.
Comes with the restaurants.
Yeah.
Well, take me back a little bit. Always interested to know how our doctors ended up in medicine. So what was it, or who was it, or in this case, a combination of both that got you interested in medicine in the first place?
When I was in college, I was taking a class in cognitive neuropsychology, and I was introduced to a book by Dr. Oliver Sacks, The Man Who Mistook His Wife for a Hat. And it was
is the name of the book, not the
guy who
mistook his wife for a hat, right?
And he's written many wonderful books, and it's about how neuroscience works, how the brain works, how it affects people in real life, and it's from he was a very well-celebrated doctor, but he wrote it from a very human point of view, so it was easy to connect with.
And that's what got you interested in the brain and neurology?
It started it.
Okay. Did you always, you mentioned you were studying that, and did you have medicine did you think you were headed in that path, or is that what kind of moved you that way?
I always had an idea that I was going to be going into medicine. I liked the science, and I liked working with people. And so I felt like that was a great way to do both.
Very good. You said you're from New York originally. Did you
That's right.
grow up a hockey fan, football fan, baseball, the Mets fan still?
I was a Mets fan, 1986. That was a big year for us.
Yeah.
And last year was no slouch either, actually.
Yeah, and got a good team again this year.
Yeah.
Yeah. Terrific. Well, good to have you in the city, and thank you for being here tonight. Let's start with, tonight we're talking about stroke and stroke prevention. It'll be a very interesting program, and we welcome your phone calls here as we move through it. Let's talk about basic brain function. What does the brain control?
From a very basic point of view, the brain controls, in addition to our thoughts and our emotions, basic function, movement of your body, feeling and sensation that you're getting from your body to the brain that makes sense of it, communication so that you have your skills of language and understanding what people are saying, as well as then the coordination. So for one of my pictures I put Odell Beckham Jr. in there making that one-handed catch. It's one thing to move, but it's another thing to do it with that kind of grace and style.
Yeah, he is in New York, but he started here, by the way, at Newman and at LSU.
Just another wonderful connection.
Another connection, absolutely. And then the brain, you know, some of these things we choose to do. You know, we choose to walk, we choose other things. We don't choose to breathe. That happens automatically, but it happens, starts in the brain, right?
We don't choose to breathe, but fortunately, our brain centers are doing that for us. Our heart is beating, and there's a signal from the brain that controls how fast, how slow it should be beating. You don't choose to pull your hand away from a hot stove when you touch it. And so that reflex that pulls you back, that's a protective mechanism. It's only after you've actually moved your hand that the brain perceives the burn and says, ow, that was hot. So there's a lot of the brain that's working under the surface. It's doing things to keep us safe and keep us alive. But then when you put into it our conscious thought and our volition, it's really quite fascinating, really, what you can accomplish.
And of course, the brain remembers, okay, hot stove, don't do that again.
Exactly.
Once is enough, right?
Right.
So some debate about how much of our brain we actually use. What do you think the answer to that is?
I think that we're really using all of our brain. The whole thing is important. There isn't really much of the brain that you can really dispense with. But you're not really conscious of what you're doing with the brain. And there's a lot of the brain, there's something called eloquent brain. It's sort of a high real estate district that has a lot of very, very specific function that has to do with finding the words that you're looking for, understanding what's being said, or being able to recognize numbers, or being able to recognize shapes to put it together. It says, oh, that's a bird in a tree or something like that. But then there are the connections between different parts of the brain. And they're pretty silent, but they're extremely important in making sense of everything, so that when you read something, maybe you're seeing something that invokes some kind of an emotion or a memory from the past. And none of that would be possible without all those connections that are silently working in the background, connecting everything together.
So some debate about how much we use of the brain, but how much do we know about the brain? To me, this is the most fascinating thing. We know a lot about the brain, but we're still, as physicians in medicine, still learning about the brain every day, aren't we? There are lots of things we don't know still.
Absolutely, and that's one of the things that I really was drawn to and I find so fascinating about neurology and neuroscience in the brain, is that there's so much we don't know yet and so much left to be discovered. It's interesting if you think about it, because after all, we're only human and we're using our brains to try to understand our brains.
Right.
And so there may be some limitation. I don't know if we'll ever be able to fully understand everything. But with changes in the technology, things like functional MRI, different imaging techniques, it's really fascinating what we're learning about how the brain works and how it affects our everyday life.
All right, let's talk about the interaction between the different ares of the brain. We've talked in some broad strokes, but let's get down to a finer brush.
So very basically, our brain is a very nifty organ. The left side of the brain controls the right side of your body. The right side of the brain controls the left side of your body. If I'm looking out ahead of me, the things that I see off to my left are going to come in through my eyes, and they're going to go to the right side of my brain. And likewise, I'm looking at you from this angle, so I can see you here, is going to the left side of my brain. The movement of the muscles, the sensation from the skin and from the organs, from one side of the body crosses over to the other. And then the part of the brain that has to do with coordination, it actually does a double crisscross. But for the most part, you can think of the left side of the brain and the right side of the body, and vice versa, being connected like that.
When we say someone is left-brained or right-brained, what are they referring to, and what does it mean?
A lot of what's being referred to then really has to do with personality aspects.
Something to all this?
Perhaps. I don't think it's quite as straightforward as left or right. There's a proportion. If you're right-handed, about 85% of your language function resides on the left side of the brain. For left-handed people, it's more of a 50-50 split. So when people have injury to the left side of the brain, if they're left-handed, they're more likely to have intact or make a better recovery with language function. When people are more analytical, computer programmers, mathematicians, things that are very calculated and straightforward, maybe they're using more of the left side of the brain. And maybe when people artistic, or at least using their visual systems and making sense of their environment, using those visual pathways, perhaps maybe that's more the right side of the brain.
There's some people who are going to score 36s on the ACT, and there are going to be others like me who don't get anywhere near that. Are these people born with these brains? Is everyone born with the same brain and it develops at a different rate for different people? Or are there some people who are born get their Mensa card the minute they're born? Do we know that?
Well, we know to some degree, we know certain things. People are born with a certain potential. And a lot of that has to do with our genetic background, your parents and your family makeup. If you're a giraffe, okay, you're born and within a few hours you're running. You didn't have to learn how to run, but you can't dance. So that it's genetically predisposed for animals in the wild to learn how to do certain things to survive. If you have parents that will take care of you, will change your diapers for several years and make sure that you're fed and that you're in a safe environment, you, as fortunately as we do, you have that ability to, you don't have to have the predestined knowledge of how to do certain functions, but you can learn so much more by being exposed to different environments and being taught certain things. So that's really why babies, when we're born, we're clumsy and fumble and we don't know how to walk or speak for several years. But we have the capacity to do so much more with our brains. So a lot of it really is learned, and a lot of it has to do with the environment that we're brought up in.
And I'm assuming there are going to be outliers to all this. For example, a close friend of mine, family member, she would be the first one to tell you that was not a particularly good student. If her husband was being honest, he'd say not a particularly strong student. Perfect score on the ACT. So can it skip a generation? How does that work?
It can skip generations. I think a lot of it has to do with, there's the debate between nature and nurture. And so really, I think at the end of the day, it's a little bit of both. And how much one is fostered, how much one skill set. There are some folks that do horribly on tests, but will do fantastically well whenever it comes down to social interactions and understanding what it is that maybe somebody's trying to say, or performing an interview and knowing the right questions to ask. You have those people skills, and that's not really something that you can get on a multiple choice test.
I'll take that as a compliment, thank you. And by the way, the answers are much more important than the questions on this program, I can assure you. Doctor, which areas of the brain are necessary for functions of everyday life?
So when you take those parts of the brain, you have the frontal lobes of the brain, and they control movement, but also the planning of movement, and a lot of things about our personality and our reactions, emotional reactions to things. It's actually one of the last parts of the brain to be fully developed, and so some of that disinhibition that you might see with teenagers, drive a little bit too fast or make certain decisions, has to do with their brains not being fully developed. Behind that is a part of the brain called the parietal lobe, and that has to do with a lot of sensory, not only perception of sensation, but integrating those sensations. The example earlier about touching the hot stove, that's really a very automatic response. But then what the burn felt like, what you saw at the time, all the different things that you incorporate into your memory, a lot of that comes from the parietal lobes. The occipital lobe is in the back, and that has to do a lot with your vision and your perception of what you're seeing in the world. And then when you put all these things together, those are the parts of the brain, and it's that interaction again that allows us to do all the great things that people can do.
And you chose these pictures for a reason, right?
I did. I shouldn't talk about how fast I drive because I always wear my seatbelt and I'm always safe. But I do like watching races on television. Certain things like dancing, or I got a little photograph of Albert Einstein. His brain was phenomenal, and the mathematics and the science and the teaching and knowledge. It's hard to put a a function like knowledge into one spot in the brain. I love to eat. I like to cook. I'm not as good at it as some others, but I'm learning a lot down here. And so Paul Prudhomme, of course, is a very celebrated chef, and I think really a leader. The kinds of things that he could do in a kitchen and the way that that made people feel, those are the types of things. Trombone Shorty, playing music, which I've just been introducing to my kids lately. It's hard to say that there's one spot in the brain that lights up when you play Trombone Shorty, but I think all of us know it's really cool stuff.
Right. I'll tell you what, you picked up a lot for being here just a short while, and your kids are lucky to be exposed to all these wonderful things and wonderful people. So an aside, you know, we hear often that the teenage brain is not fully formed. But all of us have met teenagers who are mature beyond their years. Does this mean their brain has formed faster, or does maturity have anything to do with brain development and brain function?
It does have something to do with brain development, brain function, and age. Again, there are going to be ranges.
Okay.
And so you have young people that may be very mature at an early age, and maybe they've got more of a potential to learn even earlier the things that many teenagers may not be able to really appreciate until a little bit later in life. Some teenagers have difficulty with those things, and so perhaps that may explain, and it's all theoretical, but may explain some behavioral issues that some kids go through, some teenagers, and why certain things like your peer group and the exposure to the examples in your environment and the things that you learn and where you're, you know, the kind of things that you're brought up with really do shape how we develop very much.
I promise we're going to get to stroke here in just a second, but I want to promise our viewers and let the doctor know I will be asking about cell phones and computers and how that, he thinks, has changed the way our brains work and think. And there's a lot of debate about that, but I'm very curious to hear what you have to say about that. And we'll ask that shortly. But let's talk about stroke now. Take us inside of a stroke. What's happening to the brain during a stroke, doctor?
So all those nifty things we were just talking about brain function, they need nutrients. They need oxygen, they need glucose, they need a good supply of blood flow to the brain. And whenever there's an interruption of that blood flow to the brain, wherever that blood flow was going to can no longer function, that function's interrupted. And so when there's either a blockage or a rupture of a blood vessel to the brain, you lose that function. If that interruption of blood flow or oxygen is sustained, that injury can become permanent.
What happens to cause those ruptures and interruptions? What are the main causes of stroke?
There are two main types of stroke. There are the hemorrhagic strokes, in which a blood vessel ruptures. Something causes a weakness or an aneurysm, for example, where blood is no longer maintained in the blood vessels but then spreads outside, no longer able to get to where it should get, and in and of itself does damage. And then ischemic stroke, which is caused by a blockage of a blood vessel and no longer able to travel through that passage to get to the brain.
And treatment for each very different, and we'll talk about stroke treatment here in just a moment. Let's delve deeper a little bit into the two different types of stroke, one related to hemorrhaging first.
In the United States, the most common risk factor for hemorrhage is high blood pressure. High blood pressure puts a lot of strain on the smaller blood vessels, the smaller branches, and can lead over years of strain to rupture of those blood vessels. Aneurysm development, some of which is genetic in a family history type of a risk, some of which can be sporadic, and which means that you can't really
do anything about
predict
it.
You couldn't predict that it was going to happen. As far as doing things about it, there's treatment for these things when you can catch them early. But of course, these are very serious and very dangerous causes of stroke because of the bleeding and the risk that the bleeding could continue.
But the hemorrhaging stroke is not the most common type, right?
That's right, that's right. Between 10 to 15% of strokes are from bleeding. The majority, about, if you split the difference, about 87% are from blockages of a blood vessel. This can occur either in the small branches of the blood vessel. I use an example of a tree as to get an idea of what the blood vessels look like. There can be injuries to the very small branches of the tree that can affect a very focal, small area. There are the larger branches, so for example, the middle cerebral artery, which is one of the main arteries in the brain. And then lower down, there can be injuries to the large blood vessels. The carotid arteries are the two main arteries that come up into the neck, and the vertebro-basilar system is a little bit further back. And so any blockage of different areas within that path of the circulation can cause very particular problems in terms of someone's neurological function.
If I'm rushed to the hospital and the stroke center is there, and I know Oxnard has a terrific one, how are they determining what kind of, first of all, if I've had a stroke and what kind of stroke I've had, and then we'll talk about treatment options based on what they find?
Sure. A lot of it has to do with the presentation, what's happening to you. And I'll tell people sometimes that a cerebral infarction is the medical term for injury to the brain from a lack of blood flow, and you can see that on things like an MRI. But a stroke is the thing that happens to a person. You're at a meal with your family, and all of a sudden you drop your fork, you're right-handed, and your right side goes limp, you can't feel it, and you're unable to speak. That's somebody having a stroke, usually the sudden onset of one-sided symptoms. To tell whether or not it's from bleeding or if it's from a blockage, you really need to get into the hospital as soon as possible and get a CAT scan. That can show you if there's bleeding or if, well, either there's bleeding or there isn't. And putting together the clinical picture of what's happened to a person, factors like what their blood pressure might be, if they're on certain medications that would increase their risk of bleeding, or if they have medical conditions that would increase their risk of bleeding. And then what you would see on a CAT scan, that can tell you whether or not this is the type of stroke that we need to be treating possibly with surgery or something to address bleeding, or the type of stroke that we need to treat with medications that can open up a blockage, or even medical procedures that can unblock an artery.
And it's impossible for someone in their home or at the dinner table who's not a physician and without all these things you're talking about to be able to diagnose what kind of, you might be able to say, yes, this is a stroke, or certainly has all the symptoms of a stroke, but you wouldn't know which kind. So you would never advise someone to, well, that could be a blockage, let's take an aspirin, because it might be bleeding, and then you could do more harm than good, right?
That's correct. And even somebody that is a physician, you can have the director of a top neurology department in that same situation, and you just can't tell without getting that CAT scan and getting it quickly if it's bleeding or if it's a blockage.
All right, let's talk about why it's important to act fast, and at the same time, let's talk about these new super wonder drugs that we keep hearing about. For people, used to be, many years ago, you had a stroke, you may have had symptoms of that stroke for the rest of your life. In fact, that was likely the case, and some people would do better than others. But now with some of these super wonder drugs, and please talk about them, you can go in for a stroke, a serious stroke, and a year later, 3 months later, maybe the next day, it's like you didn't even have one.
Fortunately, there's been a lot of advancement in the technology, both with medications and interventions for stroke. When someone has a stroke, as soon as that first blockage happens, we're talking about ischemic stroke now, blood can't get past a certain level. Those brain cells beyond the obstruction start to suffer, and they start to die at a rate of about 1.9 million neurons. Neurons are brain cells. 1.9 million neurons per minute. That's a lot.
Yeah, what percentage of that, because you're right, it sounds like a ton, but if it's 1% of the brain versus, do you have any idea what percentage that is?
A lot of it depends on where it is. If it's the part of the brain that has to do with your language, that's your link to the rest of humanity, the rest of your family, your workplace, everybody that you ever need to interact with, whether or not you need to tell them that you're uncomfortable and you need to move your leg, or you're trying to explain some complicated concept to them. If it's that part of the brain that's affected, that's pretty crucial. There are some areas that are a bit more forgiving, but again, at the time that something like this is happening, you really can't tell.
So what are these drugs, exactly what are the drugs, and what are they able to do? What are we able to do now with these that we weren't able to do before? Prevent the damage or repair the damage that was done?
Preventing the damage is sort of the holy grail of stroke treatment and stroke prevention that we're all looking for. And so far, we haven't found anything that can really prevent brain injury in the case of a stroke. There are lots of things that we can do to prevent strokes, and we're going to get into that. The medication that's used now, that's been around for about 20 some odd years, is something called TPA, tissue plasminogen activator. It's a drug that's given IV, and within the first 3 hours, by the clock, so you look at your watch and you say, okay, well, we've got it 6:24 right now. This is when something happened, the clock starts. And you've got 3 hours, in some situations, 4.5 hours, but you don't always, they're not the same for everybody, in which you can give somebody this medication, and the potential for a good recovery, meaning that there's little or no deficit from the stroke, goes up by about 33%. In addition to that, and extending that time window a little bit further, there are interventions. And my colleague, Dr. Vidal, was here with you speaking about a year or so ago. And one of the things that he does is procedures, and several of his colleagues that do this, interventions where they use catheter-based treatments. So something that goes in through an artery, either in the leg or in the arm, that can actually go up to the point of the blockage in the artery in the brain, and using different kinds of devices that have sort of a mesh-like of a material, capture the clot, extract it, and restore blood flow. And those kinds of treatments allow a little bit more time, not days, but several more hours, and can potentially double the benefit that TPA alone can give.
Absolutely amazing. Let's talk about some of the major causes of ischemic stroke.
So as I was mentioning earlier, you can have blockages of the blood vessels within the brain, atherosclerosis, which is hardening of the arteries basically, and that can occur in a more widespread fashion within the brain in those small arteries. You can have blockages of the blood vessels in the neck, for example, the carotid artery, which is another source of either complete blockage in the neck or a source where blood clots can form and then travel downstream. Those are called thrombotic strokes. Embolic strokes are a kind of stroke that can occur where, in which a blood clot is formed elsewhere in the body, usually in the heart. And then because of irregularities in heart rhythm, certain things like atrial fibrillation, which we're going to talk about, you can have a blood clot form that then gets launched out into the circulation. If that blood clot goes down to your leg, it's going to cause a blockage to the artery in your leg, same with your eyes, or same with your kidneys. If it's going to the brain, and brain gets dibs on blood flow because it is kind of a high priority organ, most of the blood actually does get pumped to the brain preferentially. And so it's a very common source for embolic blood clots, stroke, to travel up to the brain and get stuck. As the blood vessels get narrower and narrower, the blood clots get in and they get stuck, at which point blood can't flow through them.
All these are scary things to hear for people, and we've all probably know someone who has had a stroke before. There are things we can do to lessen our chances, and we're going to talk about those in just a moment, but there are some things we have no control over that we're just born with, right? That are factors in determining whether or not we may have a stroke at some point, right?
That's true.
And what does Ben Franklin have to do with all this?
Well, Ben Franklin, I believe, was the one that said there are only a few things of which we can be absolutely certain, including death and taxes. And so, depending on your family background, there are certain risks. Some genetic conditions are very straightforward. You have one parent with it, you've got a 50% chance. Things like stroke can be much more complicated because there are so many different factors. But certainly, your gender, whether we're man or woman, there are different risks for stroke, and they can affect us at different ages. You always think of men as having more of a risk of heart disease and stroke at a younger age, and to some degree that's a little bit misleading. I don't know very many men that have ever been pregnant, but pregnancy is in and of itself a very dangerous thing for a body to go through. And so there are factors like that. As we get older, women tend to live longer than men, but because of several factors, again, some of it are uncontrolled blood pressure, the incidence of stroke as we get older, the risk of having a fatal stroke at an elderly age is higher for women. So, of course, that's something we can't really control. Our genetic background, of a family history, different racial backgrounds, and different parts of the world. In Asia, in the Far East, in China and Japan, the risk of hemorrhagic stroke is quite a lot higher than it is here in the United States. Some of that has to do with environmental factors, certainly, but there's a good proportion of that that also is genetic in background.
What are some of the risk factors we can control?
All right, so these are the things we can fix. And so you can't eliminate these risks necessarily, but there's a modification that you can do. By far the most common one is blood pressure, which we'll get into. Certain things that have to do with medical conditions, diabetes, blood pressure, high cholesterol, sleep apnea, those are things for which there are treatments, and the treatments lower the risk of stroke. And then there are the things that we do, our patterns of behavior and our diet, how much we exercise, if you smoke cigarettes, things that we can modify in terms of our lifestyle that can significantly lower the risk of a stroke.
All right, let's go delve into each of them just a little deeper. Let's start with high cholesterol.
So high cholesterol. So cholesterol is a risk for heart disease as well as stroke. And there are good cholesterol and there are bad cholesterol, and we've heard about that. LDL, low density lipoprotein. That's the kind of cholesterol that can accumulate in your blood and leads to the formation of plaque in the arteries that contributes to atherosclerosis. There are good kinds of cholesterol, high density lipoprotein, for example. And one of the best ways to raise that is by exercise. So it's all tied in together. If you're like this gentleman in my picture here and you eat the 5,000-pound cheeseburger over there.
That's the one if you finish it, I think they give it to you for free or something?
It's,
Like
well,
the porterhouse steak?
The meal doesn't cost any money, but he's probably paying for it a little bit later on.
Yeah, you go.
And so reducing your cholesterol has a significant impact on stroke, and a reduction, approximately 15% reduction in stroke for every 10% that you lower your dangerous or LDL cholesterol.
We've got some others to talk about, but I probably should have started with the single most important risk factor, and that's high blood pressure, right?
Right, and high blood pressure it's one of the greatest risk factors because not only of the impact that it has on our body for heart disease and for stroke, but because of how widespread it is. It's a very common condition, and it's something that you can directly impact either through behavioral modifications, lifestyle things like diet and exercise, weight loss, your sleep, if you smoke cigarettes. All those things will affect your blood pressure, but there are a lot of different medications out there as well. So it's really a balance between using medication and making those lifestyle changes that are difficult to do, but are really necessary in order to lower your blood pressure. And by lowering your blood pressure, you can reduce the impact of diabetes, you can reduce the impact of many other medical conditions, heart disease, atrial fibrillation. All those things become a little bit easier to control with blood pressure modification.
Yeah, let's talk about atrial fibrillation or AFib. How does that impact a stroke?
So what atrial fibrillation is, it's an irregular heart rhythm in which the two chambers on the top of the heart, those are the atria. Normally there's a signal where they pump, and then you get that pump, and then the bottom chambers will pump back. Fum bump, fum bump. That's a normal heart rhythm. What happens with atrial fibrillation is the top part of the heart sort of quivers. It's very excitable, but it isn't synchronized in its beating. So blood doesn't flow through it like it should, and it can pool and form a clot. The bottom chambers of the heart don't know what to do, so they just sort of pump along in Morse code, and sometimes they go too fast. But those blood clots that can form within the top chambers of the heart eventually make their way down into the ventricles, which are the parts of the heart that pump blood to the brain, to the rest of your body. And when that happens, those blood clots can get thrown up through the blood vessels and cause a stroke.
Diabetes was on your list. Why is that a risk factor?
Yes. Diabetes, you can think of diabetes really, even though you measure your blood sugar, and it's a condition where your body's unable to regulate blood sugar, you can think of it as a disease of the blood vessels. And it's a very, very prevalent condition. And many of us, if we aren't diabetic, we know someone that has diabetes, and we know how important it is to control your sugar because of the risk of injury to the eyes, injury to the kidneys, people that have diabetes that maybe lose feeling in their feet, have something called a neuropathy, or they don't get good circulation to their feet, and when they get cut or they get a wound, it doesn't heal very well. Same thing goes with the brain. And so if someone has, let's say, high blood pressure and diabetes, that risk is compounded. and it predisposes people to a greater impact from things like cigarette smoking.
And finally, carotid artery disease.
Yes. So carotid artery disease is when you have that atherosclerosis, the disease of the hardening of the arteries, within the blood vessels in the neck. This is where if you check
This is the one we can feel it?
Right.
Yeah, right.
Exactly.
On both sides, right?
You shouldn't check your pulse at the same time on both sides. You might pass out.
There you go.
But yes, absolutely. So you can check your pulse there. And so one thing and it's something that's not the most common cause of stroke. Perhaps about 15% of ischemic stroke is a result. But it's something you can check for. You can discover it through screening. Ultrasounds of the neck can determine whether or not there's a significant blockage. And there are treatments for it. There are medications sometimes, but surgery or more recent development called carotid artery stenting, where you can go into an area of blockage and open it back up again. And so this is something that I kind of like to discover before someone has any major problems from it, because it's something that you can fix.
All right, we're going to take a break, but before we do that, we're going to take a break in a moment, and we're going to ask you to call us. But before I do that, I want to talk about medications and the importance of those.
Okay. So with all of these conditions that we've been talking about, high blood pressure, high cholesterol, diabetes, each of these conditions has a very big impact on a person's stroke, risk of stroke. And so in addition to the lifestyle treatments that we talked about, there are medications. Now, they make a pill for everything, and it doesn't mean that you need to be on them. But in some situations, if someone has uncontrolled blood pressure, they've lost weight, they've started exercising, they changed their diet, it's not coming down. Using blood pressure medication to lower your blood pressure has a significant reduction in the risk of stroke. If someone is on cholesterol medications, there's a class of medications called statins. They lower your cholesterol, they make your LDL numbers come down, which is a very good thing when they're too high. But in and of themselves, they have an effect on the lining of the blood vessels. They reduce inflammation within the blood vessels, and so they make them less likely to have a very strong reaction if there is a rupture of a plaque. They actually smooth over some of those plaques so that it's less likely for clots to form on the lining of the blood vessels, and after all, that's what winds up causing stroke. And this was a recent study that I found really just through a Google search. Folks that have high blood pressure and have high cholesterol that are on medications for both and stop them and decide, I don't want to take this stuff, and they stop their medication, their risk of a fatal stroke goes up about 7 times it would have for folks that continue on their medication regimens. So it's really, really very important.
And all these decisions should be made in consultation with your physician, obviously.
Absolutely.
All right. I've got a couple more questions for the doctor. We'll talk about the difference between a stroke and a TIA, and he's brought along a chart that would be very helpful to you and others in recognizing when someone is having a stroke. We'll get to all of that and to your questions. We ask you to call us right now. 504-866-3200 is our phone number. That's 504-866-3200. Or you can send us questions by email at hhquestions@wlae.com. Again, give us a call right now. We'll take a break. Back with my additional questions and yours in just a moment here on Hello Health.
They say that when you're facing extreme danger, your life flashes before you. If you think that's sad, consider facing it before you even have enough life to flash before your eyes. Deaths and injuries can be prevented by using the right car seat. Visit safercar.gov/the-right-seat to know what is appropriate for each age and size.
I need help finding a doctor.
PACE.
I needed help with my medication.
PACE.
I needed help getting around.
The Shirley Landry Benson Pace Center is a place that helps seniors remain in their homes providing the care they need. If you or a family member are over 55 years old, you may be eligible for benefits offered by PACE. For more information, contact us at 504-835-0006. PACE, caring for those who cared for us.
And welcome back to Hello Health on WLAE. Tonight we're visiting with Dr. Daniel Chehebar, and we're talking about stroke and stroke prevention, a fascinating program. I've got a couple more questions. We'll get to those in a moment, but let's begin with you. On line one, Beth is calling us from Mandeville this evening. Beth, welcome. You're on Hello Health.
Hi. My question is, they always say to call 911 if somebody in your family is having a stroke, but I sometimes think that I could probably get, my family member to the hospital faster in my car than I could by calling an ambulance. So what's the right thing to do if I think my family member is having a stroke right now?
Well, thank you very much, Beth. That's an excellent question. And the right thing to do, and this is really something that in almost all situations is going to be the case, you want to call 911. And there are a few reasons about that. For one thing, the ambulance is going to be able to get you to the hospital, if not faster than you could drive there, more safely, but they can do several other things. They're going to call ahead to the hospital, and they're going to say, hello, emergency room physician, I'm here with someone from Beth's family that they think may be having a stroke. And so that's going to prepare everybody in the emergency room. All right, we've got a potential TPA patient, someone they may be having a stroke. Let's get the CAT scanner ready. Let's make sure that our neurologist or our stroke specialist is ready for them when they get here. And they can have all these well-coordinated systems ready for you so that when you do get in, because time is brain and at 1.9 million neurons per minute, you don't want to waste a second. So calling 911 allows the ambulance to get ahead quickly. And the other thing is that sometimes stroke can be very confusing, and it's not really sure if am I having a stroke, is this a seizure? As a neurologist, I know that they're very different, but sometimes they can be confusing. And so the EMS crew will be able to see somebody, and they'll be able to check, is their blood sugar too low? They can do some things right away that could potentially prevent major injuries from coming down the line, and make sure that you get the right treatment as fast as possible.
Beth, you gave the advice to Beth or the people in the ambulance can call ahead and get everything ready. When Beth calls 911, should that be the first thing out of her mouth? Is I'm calling because, as opposed to I need an ambulance, I think my husband or I think my father or a member of my family is having a stroke, which then triggers the 911 person to say, okay, we'll dispense with, tell me how long you've been feeling like this. Let's get somebody there quickly, and straight away.
That's correct. And it does actually have an impact on the dispatch from the fire station wherever they're coming from. So yes, you want to mention right away you think that someone may be having a stroke, and you want to make sure that you're calling 911, which unfortunately not enough people do. And that's one of the factors I believe that has to do with not as many people getting that treatment, that TPA, that could have. So thank you, Beth, for that question, because it really is a very important one.
Thank you, Beth. We appreciate it. Let's go to line two. John is calling us from New Orleans this evening. John, you're on with Dr. Chehebar. Go right ahead.
I wanted to call and ask him about, I have trouble remembering stuff. So I'd like to know if there's something going on with me now or what.
Probably not related to stroke, but doctor will give you a chance to answer.
There are many reasons, and thank you for calling, John. There are a lot of different reasons why people can have trouble with memory. Silent strokes can be one of them. Medications that people are taking, other conditions that can cause memory problems. That's really a big question, and I think that's the type of thing that really seeing your doctor, and if they're not able to give you a good explanation, possibly getting in to see a specialist to have special memory testing would be important to do. But for many, many things, there are, like medication, for example. If you're on a particular medicine, do you take any medicines that tend to make you sleepy, or?
Yeah, I fall asleep when I sit in this big chair. I got a comfortable chair and I fall asleep in it. And I'd like to know, too, why I fall asleep so much.
Okay. Well, you brought up something that, that I mentioned earlier, was something called sleep apnea. Now, if you're the kind of person that tends to fall asleep very easily when you're just sitting in a chair, you're sitting on the sofa, if you're the passenger in the car, hopefully it's not happening when you're driving, but if you tend to fall asleep very easily when you're sitting still, if you're tired a lot during the day, if people have ever mentioned that you snore or you startle yourself awake at night gasping for air, those could be signs of a condition called sleep apnea. It's going to be hard to remember things. It's hard to concentrate when you haven't gotten good oxygen to the brain at night. And that's a very important thing to check with your doctor about because, again, there's treatment for that. And that's something that can really turn around a person's life.
Thank you very much for your call. Our phone number is 504-866-3200. That's 866-3200, and we do have phone lines open. You can also send us questions by email at hhquestions@wlae.com. Doctor, I want to talk about the difference between a stroke and a TIA, sometimes referred to as a mini stroke, but really isn't a stroke.
It is and it isn't, really. Earlier I was talking about a stroke, which is the thing that happens to a person, and a cerebral infarction, which you can measure, which you can usually see with a test called an MRI. A TIA, a transient ischemic attack, is basically the same process that leads to a stroke that causes an interruption of blood flow to the brain, but it only lasts for a limited period of time. Usually it's less than an hour. It can last for several hours, but the important thing to know about that, there are several important things. At the moment, when you're having this experience, you don't know if it's going to be a full-fledged stroke or if this is going to go away. And it's not the kind of thing that you figure it's going to go away. You shouldn't say to yourself, that was weird. Well, let's just move on with life. You want to stop and take notice of that because people that have had a TIA, about 1 in 3, go on to have a full stroke where those deficits and that injury to the brain doesn't go away. And so there's an opportunity where you say, all right, I don't like to call it mini stroke because I think of mini poodles and mini bagels and they're cute. There's nothing cute about a TIA or a stroke. So a TIA, but there's an opportunity where if you can recognize what were your risk factors, why did this happen? You have high cholesterol, you got a blockage in your carotid artery. Well, we're going to do surgery and we're going to fix that. We're going to start medications. You got to quit smoking. We're going to do all these things and take steps to prevent that stroke from coming. That's why a TIA is so important. And you should never, ever let the symptoms of a stroke or a TIA go without any attention.
All right. Back to our phone lines. Let's go to line 1. Della is holding. Della, thanks for calling. You're on with Dr. Chehebar.
Hello?
Yes, go right ahead, Della.
Hello.
Okay, I have like a lot of numbness in, like she was talking about neuropathy, and when I sleep at night, it's like on like that side gets numb, and I switch over to the other side, and that side gets numb. And I also have like every once in a while I notice like a drooling, like a slight drooling. Is that the sign of a stroke? I do have diabetes and sleep apnea and hypertension.
All right, thank you for calling, Della. Now, you answered a question I was going to ask you if you had diabetes, because in the United States, one of the most common causes for neuropathy, which is when the nerves to your feet, it starts in your feet, when the nerves aren't functioning properly, people can experience numbness, they can have trouble with their balance. It can be very painful sometimes. It tends to get worse at night for some reason, where that painful burning or stinging, pins and needles feeling in the feet. Now, it sounds like what you're describing may be more a peripheral neuropathy, which instead of a problem with the brain, may be a problem with the nerves. However, you did bring up a couple of very important points, which are your sleep apnea, your high blood pressure, and your diabetes. And so doing what you can to control those risk factors, making sure your blood sugars are under good control and that you're eating a healthy diet, which is easier said than done. Making sure that you don't, I hope you don't smoke, do you?
Not smoke.
You don't?
Yeah.
Good, good. All right, don't start. Don't start. But you've got those risk factors, and so those are important. But I would say that if you're ever concerned that you think that maybe those might be the signs of a stroke, that's the type of thing that you would at least want to start out with your family doctor to look into, because everything that you're describing could be a potential risk for stroke.
All right. Della, thank you for your call. Let's go to line 2. Gary is calling us from Harahan this evening. Gary, you're on Hello Health. Good to have you with us.
How you doing?
Go right ahead.
Hi,
We're
Gary.
fine.
Okay. My question is, what's being done, or what would be a good equivalent to Prilosec? But since they know it causes dementia now.
All right, that's a good question. There's some debate about it. I'll be honest with you.
It's a recent report where it's been linked to dementia. That's right. But yeah, right.
Well, rather than Prilosec necessarily, just those proton pump inhibitors.
Right.
If someone were asking me and coming to the office to see me for memory problems, I'd advise that they come off of them. There's a different class of medications. They're called H2 blockers. They work a little bit differently. They don't directly affect the acid production in the stomach like the proton pump inhibitors do. But as far as I know, there's nothing that would pose an increased risk from these H2 blockers. And histamine is the function. And so things of that nature, other kinds of antacids. Sometimes your diet can change things. Again, I'm going to say this 1,000 times. If you smoke, you don't smoke, do you, Gary?
Oh, sir.
Good. All right, don't start. Smoking does increase the risk of acid production. You take anything that your body can do normally, and how do you mess it up? By smoking. And so anyone that does smoke cigarettes, quitting reduces stomach acid, reduces acid reflux. But again, I think maybe talking with your doctor about some specific things, and there may be some very unique situations for you, Gary, that you'd need to talk to them about.
Gary, thank you so much for your call. We appreciate it. Our phone number, 504-866-3200 is our number. Let's go to line 1. I think we have Della now. Della, is that you?
Yes, I got disconnected.
Okay. Thank you for calling back. Good to have you with us. Your question for Dr. Chehebar.
He was telling me about the, he saying something about the neuropathy and the sleep apnea.
Della, do you have a mask that you wear at night, something called CPAP?
Yes.
You do?
I do.
All right. Does it fit you comfortably? Can you wear it through the night?
I wear it. Yeah, it's all right. I guess I'm probably for another fitting, but I do wear it every night.
Okay, good. Because those masks, they work well when someone can wear them for at least 5 hours over the course of a night. And they're not easy. If you think of sticking your head out of the window when someone's driving 120 miles an hour, that wind blowing into your face can get pretty uncomfortable. And with changes in the technology, there are different kinds of masks. People can wear full face masks, just masks that go through the nose. There are different materials that they use, different pressures, machines that don't make as much noise. And so when someone does have sleep apnea and they can't tolerate the mask, it's really worth it to check through. Now, you mentioned that you can wear yours pretty well, right?
Yeah, I wear the one through the nose.
Okay, good, all right. The other thing that's important is every now and then to check back with your sleep doctor to make sure that the pressure that they're using at night is set appropriately, because if the pressure doesn't cut it for you, it might not be working. But the number one most important thing that someone with sleep apnea can do, again, easier said than done, is weight reduction. If you can lose weight, and it doesn't have to be a lot, 10 to 15% of your body weight, a change in that can have a dramatic impact on not only your sleep apnea, but high blood pressure, control your diabetes, and that can make a big, big difference.
All right. Della, thank you so much. We're in the lightning round. Got just a couple of minutes left and 2 or 3 things to get to. I promised our viewers and you that I'd ask you about technology and how that might be changing the brain. So, you know, it used to be we'd have a conversation, we'd have dinner together, I'd get to meet your family, you'd get to meet mine, we'd have a 2 to 3 hour conversation. If the Astros are playing now, my Houston Astros, you know, every minute or so I'm checking to see, and I've got like the mouse with the cheese, right? I've got to get to it, and I've got to see who's at bat, and you're going to find out, you want to know how your Mets are doing. And we're reading now on these, we're always, it's information I don't want to call it information overload. Maybe you don't see it that way. But are our brains being rewired?
I think that they are. And if you really think about, how we're developed to take in our environment. And whatever it might be, if you grow up in the mountains, you grew up by the ocean, your experience is going to be a little bit different, but what you do at the end of the day with that information is what makes the difference. And I think using digital technology, when my daughter was a baby, she saw a picture in a magazine or a plain photograph, and she started swiping it because she thought it was supposed to change it. That's just what she learned as an infant. But I think the real take-home point with the information is to realize that you can use that information, and you have to remember to critically analyze it, because some of it might be less than reliable, but if it makes you ask a question and it brings up something in your mind that is important to you, then I think that the main importance of it is there.
All right, you do brains for a living. Do you set any limitations on how much time your daughter spends on a computer or on a phone?
Yes, they don't adhere to them, but I try to. In particular with sleep. Now sleep is, we're a little bit off the subject. Nighttime or even during the day. Those bright lights, those screens, the stimulus, they're playing video games and they're playing like that, they get revved up, and it overstimulates their brains. And children especially, but all of us, sleep is so vitally important. Proper sleep is I don't know that it's been studied as a stroke risk factor, but certainly for cognitive function and memory and thinking. The less, you don't want to have that kind of stimulation, certainly not close to bedtime.
And just for clarification, we've already talked about the brain at a younger age is still developing.
Absolutely.
And with all that sensory coming at it, maybe some questions.
Your brain is developing through your 20s.
Yeah, you go. So the last thing I want to talk about, I want to show people very quickly that chart you brought along. So if you ever have any questions about whether someone is having a stroke, or there's even any question about whether someone's having a stroke, you feel like these are good tips, right? Remember these things. Take us through it, Doctor.
This is a very easy thing to remember. Fast. Think fast when you're thinking about a stroke. Fast. Look at your face. You can do this by yourself. You can do this if you're with somebody. Have them smile. Is your smile crooked? Does one side of the face go up? Strokes are going to affect one side of your body. Earlier we were talking about left and right. So one side of the face doesn't move like it should, or speech is maybe slurred. That's down the list a little bit. Arms, you want to hold your arms out in front of you. If one arm is drooping, you can't sustain your force to lift one arm up. That could be a sign that you could be having a stroke, especially if it's on the same side as the facial droop. Speech, either it's slurred or language doesn't seem to make sense. People speak gobbledygook, or they're struggling to get the words out, and the T stands for time. Going back to that 3-hour, 4.5-hour time frame for IV TPA, time is of the essence, time is brain, and you want to call 911 as fast as possible.
Maybe not on the chart, but very quickly, writing. If you ask someone to write their name, would someone who's having a stroke be able to do that or not?
That's a little bit trickier. Language is usually language, so if they can't speak, they usually can't write. If they're weak on one side, if it's their dominant hand, they won't be able to write. And some things are very subtle, so that your shoulder or your arm might be strong, but the fine movements of your fingertips, maybe they won't be able to write, or they won't be able to play the saxophone, or they won't be able to do very fine motor functions with their hands.
All right, great information. I want to thank the doctor for the education he's provided tonight and for his continued work in the Oxnard Health System. Great to have you here. Great to have you in our city.
My
Thank
pleasure.
you so much, Doctor.
Thank you, Tom.
Okay. As a reminder, you can rewatch tonight's presentation or any of our Hello Health seminars, and you can register for our Oxnard Hello Health seminars at this phone number, 842-5669. That's 842-5669. That slurred speech was just me talking, not a stroke, and if we were having one, I've got the right guy here next to me. There's our website, oxnard.org, WLAE.com. You can see past shows right there. I want to thank the doctor again. Thank you for your wonderful questions, Humana and Oxnard, for making our program possible. We'll see you next time on Hello Health.
Hello Health on LAE is presented by the Oxnard Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Oxnard Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Oxnard, healthcare with peace of mind.
Rose first started with us, she was just coming out of the hospital.
It's been a better situation. I can always depend upon her to help me. I'm home, and that makes me happy.
We're here to get her back into her routine and be able to live the life she wants to live. It's an honor to be trusted with that responsibility.
You're watching WLAE,